As Jacinta said, my name is Faye Murphy and I'm the lead psychologist in Lucena CAMHS, which provides CAMHS services for a huge amount of South Dublin and West Wicklow, comprised of 8 teams across 5 sites. And as Jacinta mentioned, prior to taking up my role in Lucena CAMHS, I worked in the Feeding and Eating Disorder Service in Great Ormond Street Hospital. And in that role, I saw a huge number of children and young people with co-occurring autism spectrum disorders, primarily presenting to the feeding disorder service, but also presenting to the eating disorder service. And very often in that context, this would be the first presentation of young people to services. In that, what I mean by that is that they would usually have undiagnosed autism at that point, and at that point in their childhoods or in their adolescence, their eating difficulties would often be the most concerning aspect of their presentation. And as part of our assessment, we would suspect co-occurring autism, and we were lucky enough to have a specialist service to diagnose that for us. In Lucena CAMHS, we don't have a specialist autism service, but we are very skilled and we're very interested in autism spectrum disorders and a wide range of co-occurring conditions, and we have a fairly robust autism assessment pathway. So now that I work in general CAMHS, I do continue to have a special interest both in feeding and eating disorders, as well as in the diagnosis and support of young people presenting to CAMHS with ASD, which keeps me busy, as there seems to be a never-ending demand for our service and for help with these issues. So today I'm going to focus on two co-occurring conditions that I have experience of assessing and treating. One is anorexia nervosa and the other is ARFID in women and girls with ASD. So ARFID, I'm sure in the presentations last week you've heard a lot about diagnostic criteria, and I'm going to talk about our ARFID diagnostic criteria. I'll quickly talk about common presentations in children and young people with autism, what ARFID might look like. ARFID stands for, avoidant restrictive food intake disorder. And then I'll think about treatment implications when there's co-occurring autism. And then I'll go on and have a brief overview of anorexia nervosa, including diagnostic criteria, think about common presentations in women and girls and treatment implications. And then I'll consider, if I haven't completely run out of time, the treatment considerations common to both ARFID and AN when there's co-occurring ASD. So the DSM-5 feeding and eating disorders category changed from DSM-4, and these are the subcategories. And today, as I say, I will focus on avoidant restrictive food intake disorder and anorexia nervosa. So ARFID, avoidant restrictive food intake disorder, obviously it predated its introduction into DSM-5, but there were different terminology used in different settings, and the field was very much hampered by there not being agreed diagnostic criteria for this group of presenting difficulties. So the criteria are disturbance of feeding or eating, which is characterized by lack of interest in eating or food, avoidance based on sensory characteristics of food, and fear of consequences of eating. And in co-occurring autism, we'd be mostly thinking about the avoidance based on sensory characteristics of food. There's persistent failure to meet the individual's needs in terms of nutritional adequacy and or overall energy intake. And this might be associated with weight loss, nutritional deficiency, dependence on tube feeds, or impairment in psychosocial functioning. And this was really important in the field because prior to that, weight loss was an essential criterion, and many children we know who have very, very restricted diets could actually have normal weight or might even be overweight, and so they didn't meet criteria for any sort of condition despite maybe being 11 years old and drinking from a baby's bottle or whatever. So this was a great change, and it brought in a huge number of kids who wouldn't have met criteria in the previous DSM-4. So limited food intake isn't due to food not being available, and the restriction and avoidance is different to anorexia or bulimia because there are no associated weight or shape concerns. The young people are not trying to keep their weight down, and it's not explained by another medical condition. Okay, it can co-occur with another condition, but only warrants diagnosis if it needs treatment in its own right. Okay, so what might it look like clinically? It might look like a sensory-based aversion to the sight, smell, taste, texture, temperature, or a combination thereof of the majority of foods, leading to an extremely restricted diet and a negative impact on social development. So, for example, I said earlier, like a reliance on baby food or purees in an older child, and there's sometimes an associated fear of choking or swallowing, and it's consistent with the rigidity and insistence on sameness and routines that's sometimes seen in ASD. There are often pronounced sensory issues, so young people or children with these sorts of difficulties can often get stuck on one brand. They can't move from Kellogg's cornflakes to Lidl cornflakes, for example. The smells are very potent to them, and the texture of food can be really aversive. And then poor nutritional intake in turn can compound the behavioural difficulties that might be part of their autism, but this should really be viewed as a problem in its own right that deserves attention and intervention, and it can be extreme and very difficult to treat. So there's a theoretical model here that is thought to underpin ARFID, and if you look for the purposes of ASD, the biological predisposition in this slide would be the sensory sensitivity, which would lead to negative feelings and predictions about the consequences of eating. And then there'd be a food restriction that would feed back into those negative feelings and predictions, but also lead to potentially nutritional compromise, which in turn might lead back to food restriction. Presentations associated. So when we think about treatment of these kids, how do we treat them? How do we approach it? Presentations that are associated with really strong sensory aversion can be particularly difficult to treat. The first thing we need to do is ensure nutritional sufficiency, as restricted diets can be extreme and can be associated with all sorts of negative consequences. But if the young person is motivated to change, you can approach following a collaboratively set goals using an exposure hierarchy in vivo. So by which I mean, that's a fancy way of saying helping the young person to introduce nutritionally beneficial new foods in the clinic and using behavioural experiments outside of the clinic. And I have done this several times. We've been in the local McDonald's and various other places with young people trying to introduce new foods into their diets and in more socially acceptable environments. And sometimes they can be very much helped by the use of adjunctive relaxation techniques if there's high anxiety. So I'll quickly move on to anorexia nervosa. I could talk about this all day, so it's absolute torture trying to fit it into 15 minutes. The DSM-5 criteria for anorexia nervosa are persistent restriction of energy intake leading to significantly low body weight, an intense fear of gaining weight, which kind of sets it apart from ARFID in that children with ARFID aren't concerned about weight gain or weight loss, persistent behaviour that interferes with weight gain, and disturbance in the way one's body weight or shape is experienced, and then an undue influence of body shape and weight on self-evaluation. So you overvalue the shape of your body. It contributes in an extreme way to your evaluation of yourself, and a persistent lack of recognition of the seriousness of the current low body weight. And so anorexia in women and girls with ASD, in terms of research and prevalence, then as far back as 1983, Christopher Gilberg suggested that anorexia might be the female form of autism based on his observation of families of people with ASD. And in 2012, a longitudinal study of AN from the same group identified an important minority of subjects with social communication deficits consistent with the then DSM-4 criteria for autism. I remember 20 years ago as a research assistant at the Maudsley, there was a huge amount of interest in autism and anorexia when I worked in the specialist unit there. And I was slightly dismayed to see that the field hasn't moved on enormously since then in terms of how to approach these difficulties and what treatment adaptations might be helpful. Later studies have consistently shown that 20 to 35% of women with anorexia nervosa meet criteria for autism, which, when we think about the prevalence of autism as being around 1%, is really quite striking. So why are the rates so high, you might ask? And some researchers have suggested that it could be the effects of starvation. So one theory is that autism traits are secondary to starvation, and they lead to a pseudo-autistic presentation through a starvation-induced cognitive rigidity, for example. However, this is unlikely because prevalence rates have been shown to remain high in those who've recovered from anorexia, and retrospective studies have indicated that autism traits predate the onset of anorexia in a significant number of women and girls. So that the autism, for example, studies where they've interviewed parents of people with anorexia nervosa, they're able to give kind of accounts of their development that precedes the onset of the anorexia. So this is a fantastic new model by these authors, just really recently published, that sort of sets out how these things might fit together. So you'll see to the left the areas of autism related to difficulty, so sensory sensitivity I've mentioned, interoceptive ability related to eating, digestion, bodily changes, understanding and regulating emotions, social interaction and relationships, intolerance of uncertainty, rigidity.
Sorry, just letting you know you're 2 minutes.
I have 2 minutes left.
Yeah.
Oh goodness me. Okay, I'll have to hurry up. Okay, so that those difficulties can there's a direct pathway in this model that restrictive eating becomes a coping mechanism to deal with some of these phenomena associated with ASD, and then the starvation feeds back into those. Or there's an indirect pathway where there are moderating factors like bullying, or, for example, unrecognized autism, and then there's the negative emotional consequences can come into play there. Mental health difficulties, impacts on sense of self, and feeling overwhelmed. Okay, so we also know what are the implications for treatment. In my last 2 minutes, we know that of all anorexic patients, those with high autistic traits benefit the least from current treatment approaches and have particularly low recovery rates and levels of functioning. So they also require greater treatment augmentation, so that might be more sessions or inpatient treatment. So it's important, therefore, that ASD is identified, addressed, and appropriate treatment adaptations are made and adjunctive treatments are offered. For example, cognitive remediation where indicated. You can look up cognitive remediation. I have a bit of a slide on it, but I don't have time to go into it in more detail, but it's using neuroscientific findings to in clinical practice to change thinking styles. It's not a treatment in itself, but it's an adjunct to, for example, cognitive behavior therapy, and it addresses some of the more rigid thinking styles and targets the neuropsychological phenomena that we know are common in women with both anorexia and autism. And alexithymia is another very interesting area. There's a very recent study that you might want to look at that looks like alexithymia might be the key to the elevated risk of eating disorders in women with autism. And alexithymia is a difficulty in identifying and labeling one's own emotions. I was going to talk a bit about ARFID versus AN, but I've run out of time. So the take-home message would be that adjunctive treatments are certainly promising. There's a bit of a way to go with them, but that I think all clinicians should have parallel training who are treating anorexia and ARFID and similar difficulties should have parallel training in identifying autism, assessing autism, and adapting treatments accordingly. Okay, thanks very much.